Good morning and a very warm welcome to the Health Evidence Review Commission's March 2024 listening session. Thank you for being here and helping to improve Oregon's health plan members' care. This meeting is being recorded. First, Spanish language interpretation is being provided. So everyone, if you would please, I know you've heard me talk about this since you came in, but please would you click the world icon at the bottom of your screen and select English or Spanish. You will not be able to hear the conversation if you stay in the default channel. Thank you. A reminder about language interpretation when reading from a script. Please speak slower than you normally would. That allows time for translation. Fun fact, people tend to read faster than they speak off the top of their head. We want to find improved ways to include more voices in our process and value any input about the ways we can improve listening sessions, from registration to content to anything. And after this meeting, there'll be a survey link. I'll stick around after the adjournment, post the link in chat, and stick around for questions. We'd really appreciate it if you could help us with that information. So to let you know, this is not a commission meeting or a subcommittee meeting. No policy decisions will be made today. Our purpose is to provide a space to listen to concerns and suggested topics, and for staff to answer and ask questions related to the commission's work, which is to review evidence and set coverage policy for the Oregon Health Plan. In the year since we've been holding these sessions, we've seen these discussions help improve coverage policy and access to important services for OHP members. However, the commission doesn't have authority over rates, licensing, and quality standards. Today, our staff will listen to and ask questions, and staff may consider recommending changes to the Health Evidence Review Commission. Staff can't make decisions on behalf of the commission or any part of the health authority. But if concerns and problems come up that can be addressed by any part of OHA, we'll help connect you with those resources. A quick note about audience participation. We're asking each presenter if they'd like to have the audience in the conversation. If they do want to have their time used for raised hands, we'll call on people. At this time, I'd like to turn the meeting over to Dr. Ariel Smits. Ariel?
Good morning, all, and thank you for coming. We really appreciate you taking your time out of your day to come and connect with us. I just wanted to echo what Daphne said. This is not a commission meeting. We're just here to listen. And this is hopefully an open space for you all. Again, we can't, for individual cases, we can't we can't make a decision about your individual case, although we can give you resources if there's some place that we think that you could get some help for your individual case. This is more for for larger topics. Yeah, and I know we have a couple of great topics on the agenda today. Daphne, do you want to tee those up?
Absolutely. Our first presenter's name is Yahya Hakiki. Mr. Hakiki wants to talk about cultural circumcisions for boys. In other words, a surgery removing the loose skin covering the end of a boy's penis. That's called the foreskin. It's often done for religious and cultural reasons. Mr. Hakiki, you have the floor.
Good morning, welcome.
Try to find the unmute button again. I apologize. Last couple of years and the technology is still an issue. So thank you so much for giving me the space to talk today. I just want to start off by introducing myself. My name is Yahya Hakiki. I'm the president and CEO of the Afghan Support Network. We're a grassroots organization that started in September of 2021 in direct response to what was happening in Afghanistan and the large influx of Afghan refugees that were coming to our beautiful state of Oregon. And this, as an Afghan refugee myself, someone that has gone through the resettlement process, I and a couple of other community members felt a responsibility to support these newcomers, especially given such a large number that were coming at the same time, to ease the path for them a little bit and make sure some of the struggles that we had dealt with, that those struggles could be alleviated. We do a variety of different type of support. A lot of our work is kind of a wraparound support for folks that are getting resettled. That whether that's education, that's employment, whether that's housing, and a lot of the areas that we've had to really focus on is actually health. So the issue that I wanted to talk to you all about specifically today is to advocate for the coverage of circumcisions under the Oregon Health Plan for all ages, and not just infants. So currently, some CCOs cover infant circumcisions, some do not. There's inconsistency in the system, which creates a lot of confusion, creates issues for parents, etc. And there's it only covers just infants. It doesn't cover, I think it's like anywhere from, I've seen 6 months to up to 2 years, but then the coverage stops. The issue is, in the last 2.5 years, a lot of Afghans that arrived here, they did not, some kids were born on the plane. Some kids were born in the government camps. Some were born while those families were in the hotels. Folks were just trying to get settled, just meet their basic needs, and that was not something that they didn't speak the language, they weren't thinking about it, and especially in the Afghan culture, circumcision sometimes doesn't happen until you're 6 or 7 years old. There's actually a whole ceremony around it. People come together, there's a party, there's singing happening. It's a big cultural event in a boy's life. So a lot of these parents, they hadn't really been thinking about it. And now when those kids are 4 years old, 5-year-old, 6, 7, 8, etc., a lot of folks have been reaching out to us and asking, hey, I need to get my child circumcised, but the insurance will not cover it. And some of the estimates I've seen have been $30,000, $40,000, $50,000 for that, which is not something any family can cover. And this can have a huge impact because it's so tied to the religious and cultural identity, and more so in Afghans, the cultural identity of Afghans, because there's, like I said, a huge ceremony and everything involved with it. It's such an important cultural piece of it, that it can have a huge impact on both the child's life and when they become an adult. I've heard cases of adults not getting circumcised, and when they get married, their wife refuses to sleep with them because they're not circumcised. And I just want to really clarify the huge impact it can have on folks. I also want to highlight that this, isn't just something for the Afghan community. Muslims in general, circumcision is a big part of the Muslim identity, as well as the Jewish, and there are other cultures that also do this thing. And I think a 2014 study by Pew Research showed that 1% of Oregonians were Muslims and 1% were Jewish. And I believe that statistics has changed. Just looking in the last 2 years, we've had at least 3,000 Afghans join this community. So that number is definitely increased. And we did a really brief survey last night, like a really last minute survey where we reached out and did a quick poll, and we had It went out to about 100 folks. We had a 26% response rate, which is a really good response rate. And half of the folks that responded said that they have somebody in their family that needs to be circumcised, a child in their family that needs to be circumcised. That really shows just the big need for this in our community. And there's a lot of health benefits to circumcisions as well. And just to briefly speak about both some of those health pieces as well as the cultural side and the impact it can have, I would like to call on Dr. Abdurrahman Rahim. He's an Afghan doctor, and Abdurrahman, if you could please raise your hand so that you can just have a few minutes. I'd like to give you space to talk about the health benefits and how you've seen Afghan patients be impacted by not being able to have circumcisions.
Hello.
We can hear you, Dr. Rahim.
Excellent. Hi, my name is Dr. Rahim. I'm board certified in family medicine, and I practice here in the Portland area. I also happen to be Afghan. I was asked to speak about some of the health benefits of circumcisions. So there's quite a few health benefits that we've seen over the years. Multiple studies have consistently shown that males who have been circumcised have lower rates of urinary tract infections. There's also studies that show that there's lower risk of penile cancer, specifically squamous cell carcinoma of the penis. It actually also reduces the risk of cervical cancer in females with those who have partners who are uncircumcised. It also decreases the risk of viral STDs, and this does include HIV. It also decreases the risk of penile inflammatory and retractive disorders. So these are disorders where there could be inflammation. There could also be constriction of the foreskin on the penis. And this is actually something I've seen myself multiple times when working in the ER. Patients will come in and they just have a restriction because of the extra foreskin. And speaking to my colleagues, we expect to see more of this happening as people in general are getting less circumcised here in America. And then the final thing that I want to talk about was, in general, when males are circumcised, hygiene becomes easier. And this is something that sounds sort of simple, but not so much for Afghans possibly, as typically in Afghan culture, talking about this stuff is taboo. In addition, most don't know how to really teach their kids how to do this because everyone's pretty much circumcised. And so improper hygiene can cause a lot of problems and can lead to a lot of inflammation and other things that we worry about. And it may be as simple as us talking to your doctor, but this is something, like I said, a lot of Afghans feel very uncomfortable talking about. And that might change over time, but as of right now, especially with the newer Afghans who are affected by this, it's definitely something that they feel uncomfortable talking about. There's also been some anecdotal things people have talked about that it could cause sexual dysfunction or other issues, but the evidence really shows that when they've looked at surveys at sexual satisfaction, specifically with males, there's no differences. And then the risks in general are quite low. There is a risk of bleeding, but those risks are very low. And in general, the bleeding risk is rarely anything that causes serious harm. I used to do circumcisions as well when I was a resident. I don't do them anymore because I see mostly adults, but it's not something that is high risk in general. Those are just some of the health benefits I wanted to discuss today. If anyone has any questions, I'm happy to answer them. Otherwise, it was nice talking to you guys, and thank you for your time.
Thank you.
Thank
you.
you.
That's 10 minutes.
If I can just wrap it up, Daphne, if that's okay.
Yeah.
Just want to we've really briefly talked about some of the issues facing the communities and some of the health benefits of this. I think, I want to highlight that circumcisions could be long-term cost saving because, if we do circumcisions now, you're not going to see some of these issues in adults later on that Dr. Rahim talked about. So I really urge that, that the commission considers extending coverage of circumcisions, first of all, to all infants, but also to all ages. I think it'll have a huge impact on everyone that does them, honestly, but especially a huge impact because it's so closely tied to the identity of being an Afghan and being a Muslim in America. And of course, this is a great way to recognize the immigrant population and make sure that they're feeling welcome and a part of this community.
Can I just ask you a question?
Sure.
In Afghan culture, is it acceptable to do infant circumcision, or is that not an acceptable thing?
Yeah, yes, it is. It is an accepted thing. I think culturally they've waited a little bit before they've done them, but there's more and more folks doing them at a much younger age, like when they're born.
Okay.
Now, but if you go to Afghanistan right now, usually 5, 6 years old is when they start doing the circumcisions. And the issue is that a lot of those folks that have come here now, they just didn't have the chance to do it. Right? They were, because of those very specific circumstances, folks that have been here, they're usually circumcised. And what we don't want is people going to Mexico or having to travel overseas or having to travel to Afghanistan where they're in danger, like their lives are in danger, just so they could have their kids circumcised.
And in Afghanistan, or with this population, when they're here with a 5 or 6-year-old boy, do they typically have this, as a medical procedure, like with, a physician? Because I know in like Jewish culture, there's frequently a mohel who's a religious person.
No, it's always done by a doctor
Okay.
over there. Yeah, it's not. I've never seen just some clergy or anyone do them. They don't know how to do them. It's
Okay.
yeah.
And then I guess a follow-up to that is if a elementary age boy needs to be circumcised, they need to be actually usually taken to the OR and given anesthesia. Is that an acceptable risk?
Oh yeah, I mean, I would my personal experience. I think around 6 or 7 when I got circumcised. I went to the doctor. They, was put under anesthesia, got circumcised. Um, went back home and I didn't go to school, I think, for like a week. I don't think that's probably the case anymore. But I just remember there was a lot of chocolate. There were a lot of people singing and dancing. I was, really young, but I remember like that part of things. So it's a very, it's a part of the life. It's something that's expected, right? Like we do something when, a kid has their first tooth. There's a whole thing, like you make a dish. It's actually called ghash kocha. Ghash means tooth, and the dish is called kocha. And you go and you give it out to your neighbors as a celebration. And this is another like celebratory moment in the life of a child, specifically a male child. So it's a big part of it. And again, now being in America, that doesn't happen because circumcisions are not covered. The longer you wait, the more expensive they get. So a lot of Afghan families just have them when they're born. But these folks didn't have the chance to do that, or folks that are coming now that are waiting for their kid to turn a specific age did not have a chance to do that.
But I guess thinking about this from sort of a stepwise perspective, adding universal infant coverage would cover the people going forward, but not the ones who've.
Yeah.
Okay. Yeah.
Did you have any
Any-
more questions and any questions from the staff?
Any questions for us, Mr. Ahiki?
No, and I think Dr. Rahim is still on the line. So
Mm.
if you have any medical questions, he's more than happy to answer them as well.
I guess I do have a question for when this is done in older children, is it done in an ambulatory surgery center or a hospital or either one, or I assume it's not an office procedure if there's anesthesia, is that right?
Dr. Rahim, I don't know if you can speak to it, how it is done here.
We may have lost Dr. Rahim.
Dr. Rahim? Okay, we might have lost him. I think he's at work, so he might have just stepped out to see a patient. My understanding is it does require anesthesia, so it has to be. I'm not a health physician and don't understand some of those things, but I think for older adults, I remember I can speak for my own experience. I was taken to a hospital to have it done. I was really young. I don't know if it was a clinic or a hospital, but it's a
Right.
I know
Here it would
when
be a
older
hospital.
boys need something like this, currently for medical reasons, it's usually in a hospital in the OR.
Great. Well, thank you, Mr. Akiki. We really appreciate your time and involving Dr. Rahim. And would you be able to provide his email address to me in case Dr. Smith would like to get a hold of him?
Of course, I'll
Okay.
definitely do that.
Okay.
And I'm just curious, what are kind of the next steps? Is this?
I was about to, yeah. So we as staff write up a summary of your ask and kind of the things that you've brought up. And then we will bring that to our next meeting, which is May
18th,
16th.
16th, sorry.
May 16th. And we will let the commission know that, you brought this forward and then have a discussion there. I'm seeing what you're asking for as kind of a two-part question, whether we should do universal coverage of infant circumcision, which would be for any person, it would have to be born somewhat recently here, and then whether there should be coverage for the more complicated older circumcisions when sort of culturally appropriate. So I think those are two similar but a little bit different questions. And staff may get in touch with you or Dr. Rahim if we need any more information. And then we will kind of take, for something like this, which is kind of a whole category of service, we'll probably see what their direction is and what they want us to do. If they direct us to look into adding coverage, then we would we would have to get some more information from other partners and other part of the agency and things like that.
Yeah, I know those would be a huge celebration for folks if it does happen. And I want to highlight that the second piece of this is, I think, more important. Well, I think there should be a universal coverage whenever there is coverage, and there shouldn't be, depending on where you go kind of situation. But at least we have something where we can, switch CCOs and make sure that people get the service. There is no options for folks that are older to get service, and that is creating a lot of strife for families.
Well, thank you, Mr. Hakiki. I appreciate that. I'll be in touch with you about what's happening with this topic, and I appreciate your time. Thank you so much.
Yeah, and I'll be more than happy to testify again if needed.
I'll let you know when that's happening. Thank you very much.
Thank
Next
you.
up, we
Appreciate it.
have Amara M. talking about hypermobile Ehlers-Danlos syndrome, EDS, and hypermobility spectrum disorder. And she has some slides she's asked me to project. Now, if only I remember how to do that. So give me 1 second. I I should have opened these beforehand. Open, open, open.
Just start talking a little bit.
You
Or just-
betcha.
I'm Amara, and I appreciate this time today in the listening session. I think that's great. I just learned about these recently, actually. So I'm speaking on 2 topics today. I didn't have a lot of time to prepare, so
You don't have to prepare anything. You can just talk.
I think with the Ehlers-Danlos syndrome one, I wanted to make sure I had some things accurately, because I actually didn't get my diagnosis till my mid-40s. So I'm still learning. But I was graciously allowed to get permission from Courtney Jensimer, and she's a PhD at the Norris Lab, Medical University of South Carolina, and they're trying to identify the HEDS gene. So I used some of her information in my slides.
Amara, it's still not open.
Okay.
Are you able to show your screen? I can give you permission to do that. Oh, it just opened. Yay. Sorry about the technical difficulty.
Ehlers-Danlos syndrome, EDS, hypermobile EDS, HEDS, and hypermobile spectrum disorder, HSD. What is it and why it is important to expand awareness, OHP coverage, and equity for those who have these serious life-impacting and complex health conditions? Next slide, please.
Is this the right slide, Amara?
I think we're still on the first one. Please
Do you
don't
want, do you want me to
Second
go
one.
back or go on?
I see slide 2 would be the next one. There's a person in a white coat and
Is that the one you want?
Yeah, slide 2.
Okay. Thank you.
Hey Daphne, you probably think you're sharing another screen, but you're
Oh,
sharing the one.
no.
So that would be probably what's going on. If you just click on 2, we can probably just keep using this screen if that's what you want to do.
No, I want to do 1. No, not 1, 2. Okay, did it do it?
No.
You could just click below the first one, maybe.
yep. Just click on the slide with the white coat person and you're on the left.
On your other screen. Yeah.
Right there.
No,
I'm sorry. Let me stop and share again. I'm messing this up. I apologize, people. I'm not usually the slide sharer. Okay. Stop that. Mara, I apologize to you. Screen 2. Share.
There it is.
Okay.
The zebra is a symbol used to represent rare diseases. The zebra comes from a phrase commonly taught in medical school. When you hear hoofbeats, think horses, not zebras. This means that a physician should look for the most common diagnosis. The odds are that it will usually be the common diagnosis, a horse, rather than the rare, uncommon one, the zebra. However, this can lead to rare and complicated diseases being missed, and is the reason why EDS uses zebras as its mascot. Here's a sample lecture slide used in medical school. Connective tissue disorder. Ehlers-Danlos syndrome is an inherited autosomal, either dominant or recessive, conditions usually by abnormal collagen molecules in the blood vessels and subcutaneous tissue. While there are various manifestations and levels of severity of this syndrome, the primary manifestations of this syndrome include stretchy skin, overly flexible joints, translucent skin, and easy bruising. The information used to explain the group of hereditary disorders is broadly generalized. And I'm not going to read everything, but I just want to get this first part pretty good. It fails to mention the various subtypes of EDS and leaves out many health concerns that may be associated with the presentation of excessively flexible joints and elastic skin, despite often being assumed as benign. Hypermobility, a prominent manifestation of EDS, HEDS, can have a significant, unrecognized, and underappreciated multisystem impact on the body. Next slide, please. EDS is a group of genetic connective tissue disorders. The Ehlers-Danlos syndromes are a group of heritable connective tissue disorders. There are 14 subtypes of EDS and have specific symptoms. 13 of the 14 subtypes have defined genetic markers and are considered rare diseases. The remaining subtypes, hypermobile or HEDS, is not as rare disease. Studies are ongoing to confirm the genetic markers, as I mentioned earlier. I'm actually donated my DNA to that study. Connective tissue is like the glue that holds our bodies together. It is found everywhere. Most types of EDS share the general characteristics of joint hypermobility, skin hyperextendability, and tissue fragility. Chronic pain, gastrointestinal complications, orthopedic issues, and neurological, cardiovascular, and immunological symptoms are common. Next slide. Many people with EDS may go decades without a diagnosis. As I mentioned earlier, I was in my mid-40s before I got mine. Delays in diagnosis can lead to unnecessary treatments, inappropriate medical recommendations, a lack of necessary screening and monitoring, poor lifestyle decisions, and worse long-term outcomes. Although there is no direct treatment for EDS, early diagnosis can prevent validation, resources, and access to knowledgeable experts and management strategies. Because connective tissue is everywhere, EDS can affect every patient a bit differently, and that couldn't be more true. This can mean that some people have very different symptoms than others. It can also mean that some patients may have more severe symptoms or may use mobility aids, medical devices, or service dogs, while other patients may appear healthy on the outside. I'd say most of us appear healthy on the inside. Next slide, please. Comorbidities. What can hypermobile Ehlers-Danlos syndrome look like? Signs, symptoms, and comorbid conditions of HEDS vary. HEDS isn't exclusive to one clinical presentation, age, race, or body type. And then to the right, there's a good graph kind of showing an image of all the, and there is a lot more than this, but these tend to be the most common. And some of those include abnormal scarring, wound healing, hernias, chronic pain, pelvic prolapse, joint subluxation, joint dislocations, bleeding problems, gastrointestinal issues, tethered cord, sleep issues, Chiari, mast cell activation syndrome, spinal instability, and other spinal conditions, migraine, POTS, and CFS leaks. Next slide, please. Multiskeletal manifestations of Ehlers-Danlos syndrome. Some of the main features of EDS or HEDS are multiskeletal complications resulting from hypermobility and joint instability. This is kind of one of the key markers, I think, as growing, as a child, you start noticing maybe you injure yourself more often or whatnot. It's one of the first signs usually. Joint hypermobility, and then I also would like to, that's one of the things I think would be really great if OHP could expand coverage for braces and things like that. Joint hypermobility occurs when a joint moves beyond the normal range of motion. It can be localized to one or a few joints or widespread. Joint instability happens when joints lack proper restriction due to changes in muscles, ligaments, tendons, nerves, or bones. Next slide, please. Neurological manifestations of EDS can cause and be associated with neurological consequences and comorbidities, including spinal issues, headaches, neuropathy, and more. Spinal instability can occur in EDS, may present in various ways. The upper spine instability issues that are frequently discussed, but other spinal instabilities in the lower cervical spine, thoracic spine, and lumbar spine may be present. Spinal deformities such as, I don't know how to pronounce that one, but kyphosis and scoliosis may be present and are more prevalent in rare types of EDS. People with EDS may have disc degeneration, radiopathy, and different spinal manifestations can lead to neck, back pain. For me personally, I have severe stenosis, disc degeneration, adhesive arachnoiditis, and adult scoliosis. I developed that later in life. Brain, next slide, please. Brain and spinal cord. Chiari malformation may occur in EDS patients and is best detected by upright imaging. That's one I'll bring up at the end is I don't believe Oregon has an upright MRI, and that's been very challenging for patients that need to get that diagnosis. Other functional rib manifestations. There's something called rib tip syndrome, although it doesn't mention it here. There's slipping rib syndrome, LI syndrome, and costochondritis. My children are also affected by this, and my oldest has pretty bad costochondritis. Next slide, please. People with EDS may have multiple joint complications occurring simultaneously. As a general reminder, many different multiskeletal consequences can result from ligament laxity and do not need to have dislocations to be diagnosed with EDS. People with EDS or HEDS and hypermobility spectrum disorder, HSD, can present gynecological manifestations and comorbidities. These can include pelvic organ prolapse, urinary incontinence. I'll have to add in interstitial cystitis is another thing I have. Pregnancy complications, endometriosis are symptoms and that may manifest more during menstrual cycle. These issues are understudied in the EDS population. Next slide, please. 90% of HEDS patients experience chronic pain, or Ehlers-Danlos syndrome patients. Pain is a common complaint in EDS and varies in presentation and severity. That's very true. Most patients have pain in several body parts and experience at least some level of pain on a daily basis. Some sources of pain include spinal instability, muscle tightness, gastrointestinal, overstretching, dislocations, generalized joint pain, overuse, nerve entrapment, and headaches. Next slide, please. One issue that's very common in the community is medical gaslighting. What can medical gaslighting look like? Minimization of debilitating symptoms, telling or implying to a patient that their symptoms are not real, denying a patient's existing diagnosis, and refusal to order testing or provide care or refer to other providers. The desired changes to healthcare, what participants have to say. The medical trauma that hypermobile patients or experience.
Okay.
So you don't have to fill it.
Okay.
And then whatever you want to do, Lauren, just let me know. If you want to.
Can we mute Dr. Abdul, Dr. Rahim?
Let's see.
There we go.
The medical trauma that hypermobile patients experience due to gaslighting from doctors is shocking and greatly contributes to a lack of quality of life. Next slide, please. I have been told over and over that I am too complex or that there's nothing that can be done for EDS patients, which has resulted in disability, unmanaged chronic pain, and poor quality of life. It's very hard to find providers with complex health conditions like ours that are willing to learn about it and also willing to take on a patient, because we usually do take more time, you know, as a patient.
Amara, that's 1 minute left.
Okay. Is it okay if I go a little bit over?
Yeah, a little bit.
All right. Let's see. What I'll just try to throw in. I threw in antibiotics because that's a common issue with people with connective tissue disorder. There's flu. I'm not going to pronounce this one. So the Cipro family and all of that are ones that can cause tendon rupture and be very dangerous for people with EDS. So alternative antibiotics need to be very important. Next slide, please. And this was a list of symptoms with, well, another comorbidity is POTS, dysautonomia, I don't have time to go over today, but that's also a very debilitating condition. It's very
Daphne, I think
common.
you're one slide behind.
Sorry.
You're fine.
This
And
one?
actually, we're on the next one.
This one, you can see why I'm not allowed to run slides.
These were some comments I got from a local EDS group of people on OHP that they suggested I bring up. We could go over these more maybe, but OHP in 2022 called EDS very overly flexible joints and not covered by OHP. So I said to add, my suggestion was add EDS, HEDS, HSD, and other types of EDS to the prioritized list. Bergen does not currently have I'm not going to mention the MRI I already did. Some antibiotics, and I didn't mention that. Okay, next slide, please. I might just go to the last one.
I'm on the last one.
In closing, people with disabilities often experience a wide range of health consequences, leading to poor health and shorter lifespan. In addition, discrimination, inequity, and exclusionary structure practices, programs, and policies inhibit access to timely and comprehensive health care, which further results in poor health outcomes. NIH News in 2023 was a news release designated people with disabilities as a population with health disparities. I encourage HERC to continue the conversation and gathering of knowledge and insight from providers and caretakers who actively care for this population, experts and specialists in the field. It is quickly becoming a more understood condition, but we still have a long way to go. This is a good step, and keep giving a platform to those with lived experiences. Thank you.
Thank you, Amara. Ariel?
Thank you so much for that. So I just want to try to understand what your ask is. So I heard, I guess, what things are you in your community seeing as not covered but needed to be covered? I heard braces, I heard treatment of POTS, dysautonomia. What other pieces have you had trouble getting coverage from OHP for?
I'm just going to go back to that slide where I got the comments from, because that kind of highlights a few of them. Okay. For older people with HEDS, what used to be overly flexible joints has become the opposite. And I did want to mention that does become harder to diagnose later in life because you tend to get more actually like more arthritic and the joints become very rigid. So I think earlier diagnoses would be, sooner diagnoses, access to specialists would be a really good step. One suggestion I would think too would be maybe allowing people to have to travel statewide to reach those specialists, not necessarily stay in their CCO area, because it's hard to find, even just for a diagnosis, and then managed care could be more local. I wish OHP covered electrolytes and some supplements for managing POTS. There's no FDA-approved medication for POTS. All we have are supplements and electrolytes. Electrolytes are essential and can get expensive. I wish it was easier to access coverage for braces that stabilize joints and finger splints. This could reduce the number of ER visits for me. If OHP understood how important these things are, that would be great. It sounds like OHP might also have only one definition of EDS. I haven't confirmed this, but like not HEDS, CEDS, VEDS, that would be concerning and needs to be updated if true. The differences in the types of EDS and treatments are very different. It is really hard to diagnose mast cell activation syndrome, but allergy treatments do help. I am trying to get cromolyn sodium covered after trying a bunch of other treatments. And that, I think that would, access to like certain allergy medications, it's hard sometimes when it's mast cell activation, and that's also really hard to diagnose as well. But that's just spitballing. There's a lot. I could probably write a book about, ways to support people in the community better medically. But I know we are limited, but that's some of the topics that people brought up in my support group. Pain management's another one, which is really an issue in Oregon right now. We're still trying to get balance back. people access to good pain management. And again, this condition can vary from, greatly from mild to very, very severe. What tends to happen with the connective tissue being associated with all systems of your body is you may not heal normally from a surgery, or it may take 3 times as long. You may have wound healing issues. For me, I had major surgery last January, and it was really hard for me to access wound care. The only thing I was able to access was Zoom. That was the soonest I could get. I think otherwise, in person, it was like a 3-month wait, which wasn't going to be helpful for me because I needed care right away. But I think one-on-one time with your doctor, provider is really good. Telehealth visits are also great because sometimes people do have pretty severe mobility issues. I could try to answer any questions as best I can.
Oh, you're doing great. You had mentioned access to specialists. Is there a particular field or type of specialist or someone that the community has identified?
They kind of range from primaries to rheumatoid arthropologists, although that one tends to be really hit or miss. There's a lot of people in that field that don't understand what EDS is. Naturopathic doctors tend to be, by and large, more understanding of this and interested and knowledgeable about diagnosing this. But it really does range. The specialist I see at OHSU actually, and it diagnosed me, her wait list I think is closed, and it's been closed for 3 years. So that just kind of gives you an idea of the need.
Yeah, unfortunately, that's outside of our wheelhouse's access to, to not having enough specialists. That's a problem.
Yeah, it's
Um,
not an OHP issue. Yeah, I think the electrolytes is a really good suggestion by someone. For me, my oldest child also has POTS as well as myself. So that can add up, every month when you're paying out of pocket for electrolytes.
what type of electrolytes? Are you like a
There-
vitamin or a solution or?
Yeah, well, it's for the salt intake mainly, and to keep your fluid levels equal and balanced. That helps. There's still a lot of mystery around POTS, but as far as I understand it, the salt intake helps the blood vessels, and so that your blood isn't going to pool as fast to your feet. And so it just keeps those kind of drastic sways with the POTS more leveled out. It definitely helps, but it's full-time job sometimes managing all these symptoms and comorbidities. I mean, depending, there could be people, like I don't experience headaches or gastrointestinal issues, thank goodness, but there are other people that are, their lives are impacted by that greatly. It's just an interesting how it can manifest differently in every individual. And braces would be helpful for sure. Physical therapy is very helpful for certain people. Myofascial release for me seems to be the most effective form of massage, but that's also sometimes challenging to find and get covered. It can be a bit dangerous to go to the wrong physical therapist for people like us. So finding people that are more understanding and knowledgeable about these bendy bodies, and that we are at risk of hurting ourselves more than hurting us, is a challenge. But when you find someone good, it's nice to be able to access them. But again, it's dedication to go every week or every 2 weeks. And then sometimes people did say their visits ran out, or maybe they had pelvic floor PT, and then they needed one for cranial instability. Or it could be, orthopedic. And I think some people were complaining about their PT visits running out too fast because there were so many systems they had to focus on.
I had a quick question, Amara. I'm wondering if you think it would be appropriate to share with me who you see at OHSU, so maybe we could try to connect with them.
Dr. Guggenheim?
Okay, that's easy.
And I also get my care managed by Naturopath too.
Okay, we can talk offline about specifics, but thank you.
Has your CCO reached out to you about like care management or anything? Is that something that's available?
I haven't, I have Cure Oregon. I haven't specifically used case management for my HADS or POT. Oh, I might have a little bit with the POTS. I was trying to get IV covered, which was, that would be another thing. If you're in an emergency to have IV fluids, be able to be covered. I've used them like for my spine issues, things like that. Vision issues, my eyes are affected. And then, which you'll find out in a minute, I'm also dealing with some dental issues as well, but I've been experiencing actually some, not some great support. There's a difference with Cure Oregon's case management has been very helpful when I've needed them, versus like ODS case management has not been as easy to work with.
Okay, great. So yeah, it sounds like there's kind of a variety of things that might be helpful. And then some things would be very helpful that aren't in our purview, but staff can kind of noodle around what, might be in our purview that we could have the commission think about.
One thing for me, like I have interstitial cystitis. I had that for many years. I was diagnosed at OHSU in my 30s under surgery with the camera. But for many years, I was just given antibiotics because, like for bladder infections, even though I didn't have a bladder infection because they didn't know what it was at the time. So I had a lot of antibiotic resistance issues. And then I had kidney problems, reactions to the antibiotics. But now I know that the like Cipro family can be very dangerous. And I had kidney failure twice because I was put on those antibiotics for what they thought was bladder infections. Although I do get bladder infections, I think it's really important that, like I said, earlier diagnosis it's just an overall problem. It's not just an organ, it's just a national issue trying to get access to earlier diagnoses for EDS. But that also gives you knowledge. I could have avoided, taking medicine that was dangerous for me for many years. So, and then I was able to find, I put it in one of the slides. It's an antibiotic that starts with F. And I have it down here. Let's see. It's one that's probably used in Europe, actually, for bladder infections. And I was surprised at it. That's the one that works best for me, and I have absolutely zero side effects from. It's like one of those it's a powder you just take once. And over the years, I've had a really hard time getting like the prior auth. It has to be, for me, if I do get a bladder infection or UTI and I don't act upon it soon, it will cause flares for my interstitial cystitis that could last months. So being on top of it's very important for me. And getting access to the antibiotic as soon as possible. And for the one that works well for me, which I didn't even discover till this last 3 years, I think, it's been a pain. Like I was like, can I have the PA set in place for a year so that I don't have to go through this every time? And then there'd be like a 4 or 5 day delay. But I've not been able to get that worked out yet.
I do see we're at time for this topic, and I know that you're on up for the next topic. Did we want to move on?
Yeah, that sounds good.
Okay, great. The next topic also, Amara M, is dental. Root canals, buildup, and crowns. That's a treatment that can help save a damaged or infected tooth and prevent further problems like tooth loss and more serious infections. And Amara, you want to take the floor?
The number of states that offer extensive Medicaid adult dental benefits has increased since 2020. Although states are required to provide comprehensive dental benefits for children covered by Medicaid and the Children's Health Insurance Program, CHIP, dental coverage for adults with Medicaid that are Medicaid beneficiaries is optional for states. As a result, states have the option to limit the type or amount of services and beneficiary groups they will cover. States can also exclude adult dental services entirely. In 2020, when data was collected for the original coverage checker, 3 states, Alaska, Nebraska, and Wisconsin, plus the District of Columbia, provided an extensive dental benefit to the largest group categorically needed Medicaid adult beneficiaries, age 21 to 64. New York just added this as well. I believe 26 other states cover root canals, buildups, and crowns. Their Medicaid program, if my research is correct. Some states base root canal coverage with categorically needy, which is a term used by the Centers for Medicare and Medicaid Services, some such as poverty level, or if they're disabled. Oregon does not expand its coverage of root canals beyond 21 if they are not pregnant. Oregon does not cover root canals for back molars. I believe OHP may cover some front teeth root canals in some situations. The most common root canal happens in the back molars, however. People use back molars for eating every day, keeping the jaw aligned properly and evenly. OHP, however, will pay for extractions of these teeth rather than a root canal. Even viable teeth that can be saved. There is plenty of evidence that extractions and missing teeth can have severe and negative consequences, both medically and emotionally on people. Missing teeth shows us dramatically where we have health disparities and equity issues and can be literally seen in the OHP population. Oregon is listed as a state that has what is called extensive dental benefits, but this is misleading. As mentioned above, Oregon has very strict limits on these extensive dental coverages, such as root canal over the age of 21 and not pregnant. I just finished a presentation on HEDS, or HSD, a connective tissue disorder that can affect multiple body systems and areas. This also includes teeth, gums, jaws. There are numerous implications from extracting teeth for someone with HEDS, and we'll hear about that more in a minute. I want to take some of my time to read another patient's story, which they offered for me to share. This could be me in a few years, as this person also has similar conditions to mine. I suggested this topic as I am currently dealing with possible root canals myself right now, my very first, and I am astounded and dismayed at what I'm discovering. As of today, I have a full set of teeth, all mine, all viable. I am at risk now because of the negligence of my former dentist. I am currently working with ODS and the Oregon Health Authority's Ombuds Office and the Oregon Board of Dentistry on my complaint. This does not change the fact that I am in an urgent, time-sensitive situation to get treatment for 1, 2, or even 3 molars as soon as possible. Going too long without an implant, and this is if you did get your tooth extracted, going too long without an implant in place after extractions can cause damage so severe to your other teeth that this may likely lead to other teeth decay. This may ultimately require multiple extractions. So it can be a domino effect once you take one out. And that's just generally speaking. But for people with HEDS or connective tissue disorders in general, it's much higher of a consequence for teeth moving out of place, jaws misaligning, putting pressure. We have very weak enamel by and large. So it's just not something that doesn't come with major consequences with extractions. Finding low-income clinics, sliding scale community clinics, or dental schools is almost impossible, and most have incredibly long waits. I'm an incredibly resourceful person, and for me, it was very challenging. There is not a lot available in Oregon for this and other resources. For something not covered by OHP, there is a surprisingly small amount of options for low-income Oregonians to try and save teeth that require root canals. The second opinion I received from a dental office that estimated I needed 2 root canals and a third with a buildup and a crown. Obviously, each root canal needs a crown. Each root canal needs a buildup, but some may not need the root canal, but still need the crown. I'm learning all about this. So I did a crash course in the last 3 months. They quoted me $8,000. And then I had a third option at a clinic with a sliding scale. And they believe I may only need 1. They are more affordable, but even with the sliding scale cost, it is incredibly expensive for me, maybe $1,000 to $2,000. But you can see the vast differences in opinions and cost. On a side note, I would also like to see OHP cover mouth guards for some people with complex health. Bruxing is a common issue with people with HEDS and can also lead to enamel problems. I will end with reading from a fellow patient's experience they shared with me. And if I go over time, just let me know. My name is Emily. I've been on Medicaid OHP for over a decade. During this time, I've utilized OHP's dental services numerous times for routine dental care, cleanings, x-rays, and urgent emergency dental surgeries and procedures. I'd like to share my experience with OHP dental coverage in order to raise awareness and bring attention to areas of coverage that are lacking. I need improvement. I've always taken great care of my teeth, brushing and flossing multiple times a day. I think most of the community does. Regular dental visits for checkups, x-rays, cleanings. Despite my persistent efforts to maintain good oral hygiene, I still frequently experience cavities, require root canals, and struggle with other serious dental hygiene issues due to these medical conditions. Within the past decade, I've required multiple root canals on my bottom molars due to infection and cracked dental crowns, which had broken, both due to their age and OHP's refusal to cover maintenance on these root canals. I think these are root canals she might have gotten in another health coverage, but OHP refuses to cover the repairs and root canals that I desperately needed, offering me only one option: total tooth extractions. I tried to explain that dental extraction surgery is extremely painful, complicated, and traumatic for me because I have curved roots requiring extensive surgery each time, but OHP couldn't care less. But I had no money and therefore no choice. So every problematic tooth had been extracted, taken out completely. I was told this will always be the case in the future as well. After losing primary molars from both sides of my mouth, I no longer am able to chew food properly, which has caused me significant gastrointestinal digestive issues. In addition to EDS, I have LC, irritable bowel syndrome, POTS, and mast cell activation syndrome. All these conditions affect digestion, impeding my body's ability to break down and process food, and worsens over time, leading to serious complications. I tried pleading my case to OHP Medicaid before each extraction, but had zero empathy. My claim appeals were reviewed with any nuance or consideration for other medical conditions I have. OHP made it abundantly clear that unless I am pregnant, impossible for me due to my hysterectomy, I'd never receive coverage for dental services such as bridges, crowns, or root canals because it's too costly. Basically, the official position of the state is that poor and disabled people don't deserve to keep our teeth. Having a full set of functioning teeth, in my opinion, is a human right. Being low income and or disabled should not be a determining factor in who deserves to be able to chew their food. Yet this is exactly what my situation is. This is the position of OHP has left me in thousands of dollars of debt. Just because we're not pregnant and are low income, it shouldn't mean we have no right to adequate medical and dental care and dignity and respect. I can't afford to pay more money per tooth to get proper dental care, and OHP refuses to help me. This is the ultimate fate of patients who currently have no choice but to use OHP services. This is life-saving dental care for some of us. And that's what I had prepared today.
Thank you all.
Yeah, I just want to reflect back to you that we have heard this from more people than you. And this is something that HERC staff have talked to. This is bigger than HERC. This involves all the way up to budget and legislative input and big policy, big state policies kinds of things.
Learned a lot, in the last few weeks about where a lot of this is coming from. So I do appreciate what HERC's position is and what they can do in their power, but I think it's good that as people with my conditions, and again there's a large community of that in Oregon, tend to have a lot of dental needs, special needs. Also the Health for Wellness program, I think it's called that. I learned about that recently. I've been with my former dentist since 2012. So, and then since then, I'm having issues with her. She neglected teeth, and that's why I'm in this position. I got 2 other opinions, and there's such vast different opinions, even from 8,000 to 2,000. And some may need root canals and some may not. So I think, I don't know if that would help if there was added coverage, if we were looking at working with more community clinics or supporting more community dental clinics that work on a sliding scale already to save money, because I can imagine how that would cost the state a lot of money if they were going to the place I went and got my first opinion, if that makes sense. But it is a big for a lot of people. I appreciate
Yeah, and just just to say more clearly what Ariel said, the HERC actually does have crowns and root canals above the funding line, which is usually the way HERC expresses its desire to cover something. However, due to budget limitations that happened over 10 years ago, those benefits were cut by the legislature. And so there's just, in our space, there's not a lot we can do other than convey your remarks and those of others, you know, where we think it may make a difference. So we discussed this at the Oral Health Advisory Panel, and there were representatives from several of the CCOs there. And they said, yes, we'd love to cover it, but we need to get paid. And so that's kind of the dilemma the state is up against.
I mean, maybe there would be a start, like at least one step forward, be making some exceptions, making some people with more medical implications, more serious implications for removing and extracting teeth. For me, I have all of my wisdom teeth were impacted and removed, and I had a lot of shifting of my teeth for me, more than the average person. So, and also maybe I was thinking like resources for people that need access to community clinics or dental schools with sliding scales. Maybe that's something that would be something that CCOs, it's like, here's the bad news, we're not going to cover it, but at least help them navigate to.
Help refer to, yeah.
I had to do all that on my own, and it took a lot.
That's an interesting idea.
Yeah, that's something we can definitely talk about internally, whether there's some type of a document or a patient handout thing that would help point you to resources.
Yeah, and it would be great if there's even there's such a limited amount of them as well, and they have a lot. For me, I probably needed this care 3 months ago, but I have to wait till April to be able to even get one tooth started on, and then they're just hour-long slots. They were able to move my, this is a community dental clinic that I'm going to be using in April. I'm not going back to the first one that gave me the $8,000 quote. That's at least they had for me, because of my complexities, they were able to get me 3 appointments in April. But for the average patient that comes in for root canals, they can in, and then till that appointment's happening, then they'll make another appointment. So when there's urgent needs, that makes it harder too. So it would be good if more dental community clinics that do sliding scales and do root canals, build up in crowns, were available just in general. I know that's not HERC's area. But.
Yeah. Were there any more questions? Mara, did you have any questions?
I don't think so.
Great. Well,
I saw that you were on while we talked to our previous presenter, just to bring you up to next steps. As I mentioned before, I kind of write up just a little summary of your concerns and your asks, and then we'll bring that to our May HERC meeting. For something like the dental issues, we kind of can elevate them internally, but we'll just sort of let HERC know that we heard again that this is an issue. And then for the ILOS DENLOS, those kinds of things, kind of bringing that to their attention as well.
Thank you. I appreciate it.
well, thank you, Amara, and thank you everyone for the thoughtful and thought-provoking discussion today. Your comments are always welcome at the Value-Based Benefits Subcommittee and the Health Evidence Review Commission. And I'm going to paste the link into chat where you can register to give both written and verbal comment. Just follow that link and it will give you the instructions. And we're grateful to you for completing today's a survey about today's event. And I'm pasting that in the chat. It'll only take you about 5 minutes, and it helps us plan and facilitate better future events. It shouldn't take too long, and I'll stick around in chat after we adjourn to take questions and assist you if you need anything. So,
and just to echo Daphne, please fill out the survey. This is our 4th or 5th session, so we're still kind of learning as we go along. And any feedback you have for us about any part, signing up, what types of topic, anything would be really, we will definitely pay attention to that.
Absolutely. Thank you, everyone. I'm going to stick around. If you want to stick around with me, you can Q&A me and I'll address those questions.
Yeah, thank you again for all attending. Thank you to our Spanish interpreters. Thank you for your service. Yeah. Thanks for everyone for your time.
Thank you.
Just gonna say thank you, Daphne, so much.
Oh, sure. Absolutely. Thank you, Amar, for coming and presenting. That was really wonderful. I appreciate your time so much. I know you took some time to prepare and that we really appreciate that. Thank you, Victor and Rosie, for your interpretation. Have a wonderful day. Victor, are you still there?
Thank you for having us today and
Hey,
see you
Victor.
next time.
Victor, there's a Q&A.
Oh.
Are you able to look at that? It's in Spanish.
Oh, yes, it's, Maria was asking if the survey
Oh.
could be provided in Spanish.
Oh, yes, I will have that interpreted. That is one thing I forgot to do, and I will absolutely do that.
Okay, perfect.
Yvonne Cox, I'm going to give you the ability to talk. How can I help you? Yvonne Cox, you're on, you're
Okay.
unmuted.
Okay, I'm sorry. I thought I was speaking to you. Can you hear me now?
I can.
Okay, so basically what Amara was saying and what you guys were saying is that there's nothing really that you guys can do for the dental coverage.
About which issue, the dental coverage?
Yeah.
I'm not prepared to answer those questions, but I'm happy to answer questions about the survey if you're interested in taking the survey. So do you have any questions about that?
No, I'll go on ahead and just press the link. I was just trying to,
Okay.
I didn't understand how to work Zoom. Sorry. I didn't
Oh,
know.
it's okay. That's all right. I understand. So we're going to take that. I'm not a clinician, please understand.
Right.
We're going to take that issue to the commission and there'll be some additional discussion. And that's all.
Okay.
That's all I know.
Okay. All right. That's fine. Well, thank you.
Thank you. Thank you for coming. Appreciate it.
So.
Does anyone else have a question or need some help with the survey? I'm happy to assist. Just raise your hand and we can have a conversation. Okay, I'm going to put our chat or our, I'm sorry, our email in the chat. If you have any questions, don't hesitate to reach out. And everyone have a wonderful day. Thank you for coming.